Good evening. For those I haven't met, my name's Richard Haddock. I'm the Chair of the Board of St Vincent's Current Foundation, and it's my pleasure to welcome you here tonight to Inside St Vincent's. I'd like to begin by acknowledging the Gadigal people of the Eora Nation, the traditional owners and custodians of the land on which we are, and to pay my respects to elders past, present and emerging. Tonight we'll learn of the main insights from the St Vincent's ADAPT study, and that'll be explained to you in a moment what the ADAPT study is. We'll also learn about the lived experience of long COVID patients and what the future of treatment and care for patients with long COVID may hold. I wish to pass on apologies from journalist Tracy Spicer, who was to be our facilitator tonight and share her experience of long COVID, but unfortunately she's unable to be with us, and therefore I extend my sincere thanks to David Factor for stepping in to facilitating Tracy's absence. Thank you, David. It's wonderful to see our donors here tonight in person and also to have many of you online. I'd like to acknowledge Sister Claire Nolan, Sister Deirdre Hickey and other Sisters of Charity joining us. Shantini Naidu, the CEO of St Vincent's Current Foundation, and other members of the hospital. I'd also like to thank our panel of St Vincent's expert clinicians sharing their expertise with us tonight and who have been and continue to remain at the forefront of the St Vincent's precinct response to the COVID-19 pandemic. They are Professor Gail Matthews, Dr. David Darley, Professor Stephen Foe, and Professor Bruce Brew. David Factor will more formally introduce our panelists and provide more details on their expertise shortly. May I take this opportunity to extend my special thanks to the many, many donors that have supported St Vincent's Hospital's COVID response since the outset of the pandemic in early 2020, which enabled the St Vincent Darlinghurst precinct to meet the enormous public health challenge presented by the virus. I would especially like to thank the Sutton family, Mr. Ian Malouf, the Margaret Pemberton Foundation, Mrs. Jackie Waterhouse, Dr. Jong and Mrs. Anne Chong, the estate of Robert Straker, IMC Pacific Foundation, Angus Property and Development, the Blue Sand Foundation, and most recently the Hanbury Foundation, whose recent generous gift will shortly enable the appointment of the Hanbury Foundation Respiratory Long COVID Fellowship. I'll now hand over to David to begin tonight's panel discussion. Thank you. Thanks, David.
Thank you so much, Richard. Good evening, everyone, and welcome to this Inside St Vincent's special event. As Richard said, my name is David Factor. I'm the Executive Director of Public Affairs, Media and Communications, and I'm really very grateful for this opportunity to host this evening as MC and facilitator. Tonight we'll be hearing from all of the insights gained through St Vincent's long-term observational ADAPT study, what we know so far about long COVID, and how St Vincent's is helping patients manage in the face of long COVID. Tonight you'll hear from St Vincent's Hospital's specialists about the findings from the ADAPT study and the latest insights regarding the treatment and care of long COVID patients. It is a special opportunity, particularly for those of you who have so generously participated in the ADAPT study, to hear directly from infectious diseases, respiratory, neurological, rehabilitation and pain specialists. Let's now meet our expert panel all of whom have been closely involved with St Vincent's COVID-19 response from the outset. And I know this because I've had the opportunity to get to know them extremely well over the last 3 years, given the huge media appetite to interview all 4 of these panellists. So first and foremost, Gail Matthews is Head of Infectious Diseases here at St Vincent's Hospital in Sydney. She's also Program Head of the Therapeutics Research and Vaccine Program at the Kirby Institute, where she is conducting a number of international COVID-19 therapeutic trials. Gail is the co-lead of the ADAPT study. Dr. David Darley is a respiratory clinician at St Vincent's Hospital. Dr. Darley is also PhD candidate at UNSW and is examining longitudinal monitoring after lung transplantation to identify predictors of acute rejection, chronic lung allograft dysfunction, and graft survival. He's also co-lead on the ADAPT study. Professor Bruce Brew, on the end, is a senior consultant neurologist at St Vincent's and conjoint professor of neurology with the University of New South Wales and Notre Dame University at Sydney. He's head of neurosciences research at St Vincent's Hospital and director of the Peter Duncan Neurosciences Research Unit. Professor Brew's collaborative research findings have examined the long-term neurological effects of cognitive deficits from long COVID infections as part of the ADAPT study, where St Vincent's has joined a university-based consortium. He has led the neuro-COVID sub-study ADAPT with Associate Professor Lucette Cizik. Professor Stephen Foe is a senior rehabilitation physician and director of the Department of Pain Medicine at St Vincent's and a conjoint professor of medicine at the University of New South Wales and the University of Notre Dame. Together with Anthony Byrne, he established the Long COVID Clinic at St Vincent's, which was one of the first in the country. He is the clinical lead for rehabilitation on New South Wales Health's Clinical COVID Council and has co-authored a number of state government guideline documents on the management of long COVID. So welcome, panel. Gail, let's come to you first. Can you briefly explain what the ADAPT study is, why it was set up, and outline some of the unique challenges involved in studying recovering patients in a pandemic context?
Yeah, thanks, David. So it's really interesting, the story of ADAPT in a way, because when we set it up, and we set it up really very early on in the pandemic. So I think our first patients were starting to be seen at St Vincent's in April 2020, April 2020, end of March and April. And we had the study actually set up and running by May, which is an amazing feat if anybody knows anything about research. And the background to it was that when we started to see the patients coming to the hospital, obviously the hospital went into a sort of stand-up mode. Everybody was involved, but clearly the patients were coming predominantly through to respiratory medicine inpatients and to infectious diseases, where we were managing all the patients in the community. So those two departments particularly, and that's how myself and David sort of came to co-lead the study, we very quickly realised that these patients were presenting with a novel infection, and we needed to understand what happened to them. We had no idea that long COVID was going to be a thing at this time, and we really, I guess, envisaged it at the start really as a fairly short-term study. My background is very much in clinical trials and cohorts, so I'm very familiar with how to set things up very quickly in a very rigorous manner, so that we collect data across the board, and we collect it on a standard schedule of assessments. We do the same thing on everybody, and we do it in a certain way, so that what we call the setup is very rigorous in terms of then we can look at and sort of understand as the study evolves what we're seeing. And of course we involved colleagues and Bruce from neurology and immunologists, and we really wanted it to be a very collaborative study. So it took place very quickly. We were able to set it up very quickly, which was amazing. And then we started to follow people, and we invited and any of the people who are here today or online, I think we have some of our ADAPT participants, and I want to say a big thank you to those people, because some of them we've been following for 2 years from those early days. And we followed everybody. We followed them whether they had symptoms or not, whether they were recovered or not, because we wanted to know what happened. And we collected samples, and we collected data and questionnaires and so on. And then it clearly, as time went on, after a few months, we started to see what the world was seeing, which was that some of our patients were just not getting better. And this was at the time when long COVID really started to become a thing, actually on social media in the first instance. And so it was really incredibly fortuitous that we already had this established cohort of patients that we were following after their infection and doing standardized assessments from them. And that's one of the beauties, I think, of the study, and why it's been pretty successful in some of its findings. The challenges, obviously, of setting a study up like this in a pandemic are huge, because everybody is in crisis mode. The hospital's in crisis mode in terms of policies and, how things had to change, and we were all very much under the pump, just trying to learn about so many different new things that were happening. But we really realised how important research was, so that we could learn at the same time. And I have to also have a big shout out to people like the people in the ethics board and people in governance at the hospital, who really worked incredibly hard to push things through very quickly to get this study up and running. And usually it takes around 6 months from thinking about a study to actually getting it started. It took us 6 weeks, despite all the challenges of having to work in a very pressured environment, and that's a testament to everybody who is involved in the study, and a lot of people were.
I remember back in the day, in April that as you said, that you set up, and in my very short thinking back in the day, that I thought such a study was a luxury we didn't have because we were in sink or swim mode. And to think now, sitting here, how fortuitous it was on your part, and how extraordinarily swiftly you got the study up, given how multi-dimensional it was at the outset. But I definitely remember that was in my very short-term thinking, that it just seemed a luxury. And to think now we're sitting here, and I'm about to ask you a whole lot of very in-depth questions based on this very deep research that you've done, but based on that fortuitousness on all your parts back then. So still, Gail, how have the ADAPT participants and their data contributed to what we know about long COVID now?
So it's a good question, because when you look at the literature on long COVID that's out there at the moment, so it's taken a long time to come through, because it took a long time for a lot of these research studies to be, to start reporting. As I say, research is a long-term business. And what we see coming out now is very big data sets of tens of thousands of people, particularly from the UK and the US. And we have obviously a relatively small. It's a big study for one site. It's 200 patients, but it's actually a relatively small data set. But what we were able to do was, because we had collected both data on people's symptoms, their clinical, their questionnaires, their health, etc. But also we had collected their cells, not just their blood work, but there's what we call their PBMCs, the cells in their blood, which is quite, again, difficult to do, costly, and required a lot of effort from the lab to do it, but we thought it's worthwhile doing. So what we were able to do is to marry together the cells and people's symptoms, and then do this really elegant study, which was one of the first to really try and understand what was going on in the blood of people who were suffering from long COVID, as opposed to those who were recovered. And what we saw was this, what we call an immunological signal, which was persisting out to 4 months and then 8 months in people who had long COVID symptoms, that just wasn't there in people who were recovered, and certainly wasn't there at all in what we call our control group of people who had had other coronaviruses, which we also set up as a control group. So it was one of the first bits of global evidence to really support this idea that there was something immunologically different about people who were suffering from long COVID, or at least a proportion of those people. And that was really important because it validated for a lot of people at the time, again, a novel presentation. And I think a lot of people at the start maybe didn't think long COVID is a real thing, thought that people were just taking, a long time to recover, or they were traumatized, or that, it was in their heads, or, all kinds of things. And patients told us this. But for us to be able to actually measure this immunological signal, if you like, and characterize it really, really carefully, was very impactful. And that paper was published in Nature Immunology, one of the top Nature journals, in January last year, and it has been one of the most downloaded and cited papers in long COVID.
Wow. Gail, still picking on you. I understand that many of the ADAPT participants took part in qualitative interviews about their experience of long COVID. What did this tell us?
Yeah, so as I said, when we tried to set up, or when we did set up ADAPT, what we tried to do was to really be as collaborative as possible, and to let as many people, without overburdening our patients. But the reason for having one group of patients in one study rather than lots of different studies was to really try and synthesize this. And so what we wanted our patients to do was to contribute to a number of different initiatives, and we'll hear about some of the other sort of findings about what happened to their brains or their lungs or so on. But what we, one of the aspects of it that we involved was some of the social researchers to do some qualitative work, which is actually really important. It's more about looking at the patient's own experience and their own journey and their own story and their own narrative of long COVID and what it meant to them. And it's particularly relevant because long COVID actually is being sort of noted in the literature. It's the first patient-made illness, and what that means is it's the first illness where patients themselves have named their illness, have defined their illness, and have lent their experience of their illness to the scientific world and taught the scientific world a lot about what it means to be a patient with a particular condition. And so the qualitative work was really about understanding people's experience and their lived experience and their story of having long COVID and how that journey developed over time. And there were some interesting things that came out of it, but one of it was around patients learning to live with a new illness and some of the anxiety of that and how they adapted to that and how that changed their lives and vice versa. And that sort of qualitative data is a really important bit of the scientific puzzle in what we're starting to learn about long COVID.
Is that quite unique to have the data and qualitative mix like that?
So often what happens with research is you'll get a group of researchers who ask a question in a certain group of people, and different researchers ask their question in a different group of people, and so on, around the same sort of disease area. As I said, well, what we try to do, and one of the powers of ADAPT, and we've still got lots of things we can sort of look at, is that we have one group of patients who have contributed a huge amount of their time, but also because it's the same group of patients, we can link up bits of data. So we can link up the neurological data, for example, with the psychological data, with the immunological data, because we have it all in one system, if you like, and so it gives a lot of power to that.
In dimension, it seems, to the trial. Yeah. David, if I can pick on you now. Many patients in ADAPT underwent lung function testing. What were the main effects seen on lung function for COVID recovery?
Thanks, David. And look, before I start, I just want to acknowledge all of the participants, some of whom I can see in the room tonight. Thank you for your time and patience. It's really helped us create a really fantastic study, and we've learned so much. I'd also like to thank the Curran Foundation. It's really hard to get government-funded research, and it was really amazing to get philanthropic donor funding early on to set up the study. And of course the study team, we're sitting up here, we kind of get the limelight as the investigators, but there's so many staff from the AMR, Chloe and Nicola, and our biobanking staff that need to be acknowledged. There's so many cogs in the wheel that make a study like this run. So Just a quick thanks. So yeah, I mean, I'm a respiratory physician, and we had this novel respiratory virus, and I guess one of the main question that we had was, what kind of effect does this virus have on people's lung function? And so we did blowing tests at St. Vincent's Hospital. Over 100 patients did that. And that measures airflow in and out of the lungs, lung capacity, the efficiency of the lungs. And what was interesting is that fortunately, the majority of patients actually had normal lung function. There was a small minority of patients who had problems with lung capacity and lung efficiency. And this was mostly related to the fact that those patients had been hospitalised for severe infection. So it was the patients who really needed to go to hospital for pneumonia were the ones that we were seeing the lung abnormalities in. We have been following participants for up to 12 months with lung function tests. And I guess the good news for participants is that the majority of people with problems with their lung function tests are tending to show improvement over time. So this doesn't look like it's a sort of persistent problem that gets worse in the majority of participants. And what we're seeing is scarring of the lungs in a very small number of participants. So there's a silver lining, and there's a good message, I guess.
Yeah. So I also understand that some of the ADAPT participants underwent cardiac MRI to measure heart function. What did we learn from this?
So we're very lucky at St. Vincent's to have advanced cardiac imaging on campus, and we were very lucky for one of the cardiology groups to allow us to use the cardiac MRI for 20 patients. And we mostly focused on patients who met our definition of long COVID, fatigued, short of breath, chest tightness, going on for months after initial infection. Fortunately, the majority of those patients had normal function of the heart, but we did see some scar in a small minority of those patients. Most of those patients then went to see a cardiologist, and fortunately, the scar wasn't causing any major functional or structural problems of the heart, and we don't think there's a long-term problem with that. But the cardiac MRI component of the study has really given us a really high definition look at heart function after COVID, and helping us identify those patients that might need further investigation and management with a specialist.
So as Gail pointed out, we are now at 2 years plus after initial infection. What does the general health of the ADAPT cohort look like?
So many patients in our study completed up to 12 months of follow-up after the initial infection, but we did offer an extension for some patients to be followed up to 18 months or 2 years after the initial infection. And our honours student, Ben Chavone, has analysed the data, and it's shown some interesting results. I think feedback for the participants is that the majority of patients in the study had fully recovered by 2 years. There were a group of patients who would have met the definition of long COVID when they entered the study, so at 3 to 4 months after initial infection. Interestingly, for those patients, there were some mixed findings. About 2/3 of those patients still did have some symptoms, and some of them reported that they didn't feel like they, even at 2 years, had fully recovered back to normal. But the flip side of that was that we did see improvements in a lot of the assessments that we were doing. So in terms of mental health, adjusting to the diagnosis, quality of life, even some of the cognitive testing and the smell testing that we were doing, even in patients who did have long COVID, we were seeing some improvements. So I think there's a kind of mixed message there. Clearly there's a cohort of patients who are still struggling at 2 years, and we really need better prevention and treatment for long COVID. But our study has shown that there is improvement for a lot of people.
That's great. Stephen, we might move to you if that's okay. Given your role in the long COVID clinic here at St Vincent's, what are the definitions of long COVID and how do you make that diagnosis?
Well, thanks for that, David. Yeah, and thank you very much for inviting me and listening to some of our experiences in our long COVID clinic. The WHO definition, which is the current one, is for the persistence of symptoms for at least 2 months, but the definition starts at 3 months. Interestingly, this is underlined by the fact that you can't have these symptoms if they're caused by any other diagnosis. So it's what we call a diagnosis of exclusion. You've got to make sure that there's nothing else causing it. That creates some problems, which I think you alluded to before. There's a high level of having to live with uncertainty. So that's very difficult for patients because they've got to be able to cope with not knowing what their trajectory is. But it's also difficult for the referring doctors not knowing how much to investigate or whether to just have a watchful waiting sort of approach. And what we're seeing in our clinic is at least 25% of people have seen more than one specialist prior to being referred. And so there's a lot of fragmentation of healthcare because of this very vague definition. So a lot of specialists will say, look, I've had a look at the heart, there's no problem here, I don't know what the other symptoms are. And so then the GP will be in this quandary. Because there's no or very few multidisciplinary referral clinics like ours, they're going to say, well, maybe I'll ask a respiratory physician to look at you, or maybe I'll ask an infectious diseases physician. And so a patient will move from one to another and probably having a lot of investigations which are expensive for the patient and also for the community. So the definition is really about the persistence of the symptoms, but it doesn't really give us a lot more than that.
So you touched on the fragmentation, but what would be the most common long COVID symptoms that you are seeing, and what treatment options do you have for those more common kind of symptoms? So
the most common symptom is fatigue. It's followed by breathlessness in about a third, fatigue in about a half of the people we're seeing. And then it's followed by mental health disorders, which are about 25%, and then cognitive problems or brain fog in about 20%. And then you can have a whole variety of symptoms, from losing your hair, which isn't a real problem for me, but a lot of other symptoms that people come through with. With fatigue, we use a multidisciplinary sort of approach. So we have physiotherapists that will show a person how to exercise very carefully with a lot of feedback, because some people feel a bit better and then push themselves very hard and then become overly fatigued again. So we have to measure them out. Our psychologist teaches people about pacing. Interestingly, one of the groups of people we're seeing quite commonly to present is the very high functioning person, a person who works a lot of hours, who exercises quite hard and then has trouble coping with the long-term effects of a viral disease. And those people, we need to sort of get them to slow down and to slowly meter out their recovery. We also involve an occupational therapist, because many of them, about 19% have stopped working. 25% have stopped working for more than a month. So the impact of getting people back to work is quite a challenge. So that's the next sort of step. So we use all those people to help this one person's fatigue and to try and control it.
So I know, Stephen, you've got a parliamentary delegation coming from Canberra tomorrow. So I'm going to give you an opportunity for a dress rehearsal, because I know this is the question they're going to ask you. Can you share with us a little bit about the potential scale of the public health problem that long COVID presents to us as a society? Is it true that more than 1.4 million Australians could be affected? What sort of cost to society could we expect?
Well, that's a daunting question when I'm sitting amongst all these scientists. What I can tell you is that the scientific answer will be it's very hard to estimate, because the number of people who had persistent symptoms with the first wave will be different to the Delta wave, will be different to the Omicron wave. And we do know, the data shows that people who are double vaccinated who got Delta, around about 10% of them in Australia continued to have symptoms. The people who got Omicron and were triple vaccinated, about 5%. The WHO says that on a global scale, it's 10 to 20%. But that, of course, involves many countries that have less than ideal health systems. 10 to 20% of the Australians who've had COVID would be over 1 million, because 11 million Australians have had COVID. New South Wales Health have tried to model this and said at least 57,000 people in New South Wales will have long COVID. So it's not insignificant. And if you put that trajectory to the whole of Australia, it's going to be between 250 and 300,000, which, when you think about it, is about the number of people who have dementia. So it's not a small category. The straightforward answer is a lot of people. When we opened our clinic in March of this year till October, we've had 700 referrals. And that's pretty good because we can only see about 8 a week. So we're booked out until the end of next year. And even though we have rejected 300 of those referrals because they've come from interstate or they've come from other areas with health services, there's obviously quite a pressing need.
On that note, I understand that you're currently seeking philanthropic support to enable the appointment of a long COVID rehabilitation fellow. Why is this appointment so important, and what impact could this role have on, from a patient's perspective?
It's a great question. I've thought about it a lot over the last few days. In rehabilitation, we'll often do what we call translational research. We'll take the research that have been presented by studies like ADAPT and Bruce's study, and we'll try and transfer it into treatment protocols. Now, at St Vincent's in our pain unit, we identified that people who had a fractured hip and came into hospital were getting a whole variety of strong drugs and becoming delirious. And we worked out that a standard treatment, which was an injection of local anaesthetic, could make the person's leg numb, and they could be moved on and off the examination tables without them having to take morphine. Now, we engage with government, we engaged with other people, we taught people how to do that injection. Initially it was called the St Vincent's block, and now it's a standard treatment for fractured neck of femur in the whole country. That if you fall over and break your hip, you will get this injection in the emergency department. So what we're hoping is that a long COVID fellow in rehabilitation will be able to get used to the group of people who've got long COVID, have a look at the research that's being provided and the rehabilitation techniques, and then develop like a St Vincent's methodology or a St Vincent's method for long COVID, and be able to translate that into a standard set of treatments, and then teach people how to use it and make it something that people can expect to get if they get long COVID. So that's what we're hoping our long COVID fellow will allow us to do.
Bruce, I understand that ADAPT patients underwent cognitive screening and MRI brain scans. What are some of the important effects of brain fog on cognition, and what did we learn from the MRI brain scans?
Yeah, thanks, Stephen. So brain fog is a reasonably apt way of describing the problem, because people complain that they can't concentrate, so they can't focus on what they want to absorb. That translates then to being forgetful, and they can't hold their thoughts to organise things. So it means at a day-to-day functional level they have problems, and that can affect people in varying ways. And the other important thing is that there's not only is there physical fatigue, but there's also mental fatigue, and so those symptoms can fluctuate. Sometimes they can be reasonably okay, but after some even just reading a few pages can be quite taxing. And that can translate to not being able to work at all if they're high functioning. There's a particular patient who related that he was involved in a number of companies and would have to sort of digest the legalese and be sure that the other party wasn't ripping him off. He could no longer do that. He could, at a face-to-face level, you would think everything was fine. A brief conversation, you'd think things were fine. But getting into any sort of depth, you'd realise that there were problems. And he's now employing people to actually read the documents and then go through them very slowly with him so that he can still participate in his business, but at nowhere near the functional level.
Gosh. More broadly, Bruce, can you share with us the main findings of the neuro-COVID sub-study of ADAPT and how these findings may impact how we treat and care for long COVID patients moving forward?
So I think there are several findings. Right back when we started, from a neurological perspective, we were thinking that there could be a whole host of things that we might find, and we were focused on what was happening to the patients in the context of the acute illness. And as Gail said, we had no idea that there was this thing called long COVID. And in fact, I remember being part of a webinar looking at COVID, and someone in the audience from Europe said, "What about long COVID?" And we didn't know what that meant. And that was in the first few months. So yes, it took off in social media before it really became recognised and then accepted. Now, what do we find? I guess the first thing is that it's real. And that took some time. The second thing is that it's not psychologically based. It's not a mental health issue. Sure, lots of patients have mental health problems, understandably, but it's not driving the cognitive disturbance. Third, it's not in the non-hospitalised patients related to the severity of the acute illness. The patients who are hospitalised are a different group. They've been through a lot, and they will have deficits that are related to the severity of their acute illness. But in the non-hospitalised patients, it's not related to the severity, and it's not related to their comorbidity burden. So it's a unique disorder, and we were one of the first to actually recognise that, and it was like bashing our head against a brick wall to get people to understand. So the participants in ADAPT really contributed in a very, very significant way to understanding that as a true disease entity. And then what did we learn from that? Well, within the ADAPT study, all of the participants were involved in the neurological sub-studies, which contributed to trying to work out what was the cause. And we wondered whether it was immune activation, given that that was related to COVID. Looked at a number of markers, didn't find anything. And then when we dug a bit deeper, there was a particular part of the immune system which is a regulatory function of the body to say to the immune system, it's time to switch off, game's over. Well, that wasn't happening. This particular pathway is overactive, and it remains overactive. It produces a number of toxins, and that was the only marker, the only analyte, if you like, that was related to the degree of the presence and degree of cognitive impairment. And to my knowledge, there's no other marker that's been linked to the degree of cognitive impairment. So it was very unique. And the other, the sub-study, some of the ADAPT patients participated in an MRI study with the radiologist, particularly Joga Giganti, who was very helpful. And what do we find from that? We used some advanced MR imaging techniques to identify very subtle impairments of the blood-brain barrier. So there's this thing called the blood-brain barrier where the brain is semi-immunologically privileged. So you don't want the brain exposed to a whole host of toxins and immune parameters that the rest of the body can take, but the brain can't. In COVID, particularly in the neurologically impaired patients, there was evidence of impairment of the blood-brain barrier by this particularly sensitive technique. Not in all of them, some of them, but the majority. And so there's cross-sectional data. Then we've got a small number that we've now had several repeat studies, and again, there's improvement in some patients' resolution to normality, which is really encouraging. And the other aspect of the MR was looking at markers of inflammation, and that was very helpful in identifying, yes, there's inflammation, but it's very subtle. And that does persist for longer than we thought. The other, tying that back to the clinical part of the study, the neurological aspects in terms of cognitive impairment surprisingly don't budge when we analyse up to about a year. There's a small increase, which statistically is significant, but probably not clinically significant. So that's in contradistinction to a lot of the other symptoms.
And Bruce, this might be a bit of a naive question, but in terms of, I mean, you've spent 40 years looking at neural pathways for neurodegenerative illnesses. In terms of some of those pathways lighting up, are you seeing commonality between those?
Yeah, there is.
Or am I way off the mark here?
Yeah, absolutely. So this particular pathway is important, as I said, it's a regulator of the immune system. It's telling your immune system, game's over, time to shut down. It induces what's called tolerance. And it's a consequence of any insult, that insult being a virus, a bacteria, whatever. And in the context of degenerative diseases, it's misfolded proteins that send a signal to the immune system, we have to get rid of you. And in the context of this particular pathway, it's activated and it's not switched off. So yes, there are commonalities, and that isn't just interesting at a biological level. It's clinically potentially significant because there are certainly reports, and there's an increasing appreciation that patients who are already cognitively impaired who get COVID are at risk, not all of them, but some of them, of impairment, which is worse. It's as though it takes them down a notch in terms of their functioning. So if they're demented, some will get worse.
Right.
And one explanation of that may be this link to the pathway.
Right. Okay. Look, we've got some time for questions both from the audience here tonight, and also hopefully we'll have a little bit of time for questions from the audience online. But I think Craig's just going to hand you a microphone, if you could. Thanks so much.
I'm just wondering if research from a long time ago to do with ME/chronic fatigue syndrome contributes in any way to this, because as I understand it, that can be a typical post-viral trigger, chronic fatigue syndrome. And I was diagnosed with that some 20 years ago. I was under Professor John Dwyer. And I was terrified to get COVID because I thought I'd get a lot worse, but I didn't. I was vaccinated. So is there any link to the chronic fatigue syndrome that's been around for such a long time?
In terms of treatment. Yeah, I think it's a really good question. It's something that comes up a lot because of the similarities between chronic fatigue, ME, all those syndromes, and also sort of long COVID. I think one of the things is that for the reasons, actually COVID offers us a great opportunity rather than, when I try and think about it, rather than trying to, because we don't know a lot about chronic fatigue and ME, and the problem is that it hasn't been properly studied. It's been very hard to know what was the trigger and what happened since, and then by the time people present often, it's very hard to disentangle what's gone on and so on. COVID offers us a really great opportunity because we have these cohorts, studies of people who've been followed from the start and then are going to be followed up over time and long periods of time to really understand what having a virus might trigger for some people that may lead to ongoing symptoms for some period of time and other things like neurological complications and even other health problems that we don't understand at the moment that may be triggered by a virus at some point in your past. So I think COVID, if done properly, and there are very large studies now being set up of people with long COVID, can actually offer and hopefully some insights into the group of people who have been suffering with ME and those post-viral syndromes for some time. And to therapy, obviously, I mean, there has been no therapy, therapeutic, I'm talking about drug therapy, that's been particularly helpful in those settings. And I think the therapeutic landscape in long COVID at the moment is still very unclear. There are no good answers as to any good treatments. There are studies that are starting to be done, large studies in the US looking at Paxlovid, the antiviral, in the treatment of long COVID in case there's some virus there that needs to be switched off or got rid of. There are some, there's a very big study in the UK which is looking at different treatment arms with different options at the moment, and that will be adaptive. It will learn and it will grow as it continues. But we're a long way off having the answers for long COVID or for CFS-ME about sort of good therapeutic options. It's something we're all trying to think about and explore.
So if I can just chip in. So we did look at a control sample. So in our control samples, we had healthy controls, coronavirus, non-COVID controls, and then chronic fatigue syndrome controls from collaborators in Victoria. This particular signature pathway activation was quite different. It was not present in chronic fatigue. So from a biochemical, biological perspective, it's different.
From a treatment perspective, we've actually learnt a bit from chronic fatigue syndrome because what we saw very early on was post-exertional malaise, which has been described by chronic fatigue sufferers. So when we exercise people hard early on, they actually stopped. I can remember a young adolescent girl, we just saw her again today after 6 months, who couldn't complete her HSC. She was an athlete at school and she insisted on exercising quite hard, but then would often be unable to get out of bed for 3 or 4 days. And in fact, her HSC she had to do with periods of lying down completely. So we realised that we had to tailor the exercise to constant feedback about fatigue levels. So it has actually tempered some of the treatments.
Hi, I had COVID early 2020 and I found it affected me neurologically. My question is, what effect of getting COVID again? Have we seen any evidence on people who get COVID a second time or a third time, if whatever they've gained neurologically, whether that will erode it back to the original level, or whether it will have no impact? Do we know any of that yet at this stage?
Who wants to say?
In our experience in the clinic, people who've had long COVID from one strain, if they get a second strain, and we've seen that in about 4 or 5 cases, don't complain of long COVID a second time. So it doesn't necessarily mean if you've had it the first time that you'll get it with the other strains. Maybe it's because you've been vaccinated in between, maybe because the strains are different. So it doesn't necessarily follow that if you have it for one strain, you'll get it for another.
And about 25%, I think it was David, of the ADAPT patients have been reinfected during the study. That gives us a really nice opportunity then to look at the effect of getting reinfected on those immunological markers and so on, and see whether it does trigger the same thing the second time round. But certainly from our look at the data so far, it doesn't seem to be that when you've got reinfected, your parameters of whatever health that you're measuring go back down. It sort of backs up what Steve's saying there, that it doesn't necessarily happen that if you've had a long COVID once and you get reinfected, you're going to go back to your symptoms previously.
We've got a question from the online audience. There's a question about specific advice for those with who are immunosuppressed. Any special advice for them?
I guess I'm not quite clear whether is that sort of advice in general for people with immunosuppression, or
I think it's a broad, yeah.
Yeah, I mean, I think yes.
Yes.
Yeah. I think people who have immunosuppression at the moment are the ones that we, particularly with regards to acute COVID, the ones that we still worry about, really to some significant degree, because these are the people who can't necessarily mount good antibody responses to the vaccinations, and we haven't actually got great options at the moment for treatment of early COVID or prevention of COVID, because the variants are evolving fast and are resistant to a lot of our current therapies. So people who are immunosuppressed are the group that we do worry about. And so we do suggest that they obviously take the precautions that they're advised, and masks and so on, get the vaccinations. And we were advising them to have Evershield, which is the prophylactic antibody. Unfortunately, that is now no longer working against most variants in the state and globally. So we need new therapeutics. We need new prophylactics, particularly for the group who are immunosuppressed. There is no suggestion, though, that having immunosuppression or being immunosuppressed increases your risk of long COVID, as far as I'm aware.
So no correlation to our knowledge?
Not with long COVID.
Gosh. Okay.
I work with a group of transplant patients, and our message is always get vaccinated, at least 5 doses now. If you get infected, get early treatment. There are some oral therapies that we try, but they're not necessarily particularly effective. Some centres are giving early infusions of a drug that we give to patients who are quite sick with COVID. So it's working closely with your doctors and your transplant team, if you have a transplant, to prevent getting really sick with the virus.
I mean, the good thing is that most of the variants these days, although they are inherently more resistant to a lot of our therapies, are actually obviously much milder in terms of the acute illness than we saw with the original waves. So.
Wow. We've got someone in the audience with a question.
Thanks very much for such a thorough explanation. We've heard about some of the immunological markers that you picked up, some of the cardiac scarring and MRI, and the neurological pathway. I presume you weren't lucky enough to do the same assays in the same patients to sort of correlate, join the dots. Is it possible those are 3 entirely different markers of different syndromes, or unrelated? Or?
I think it's a great question. The way we set up the study was that we did most things on most patients at the same time points. So we had patients who did have long COVID symptoms, we had patients who didn't, and so we were able to compare groups with the same sorts of assessments. I think what I've seen and what others have seen in clinic is that there are different clusters of symptoms. So some patients have more of a fatigue type of presentation, some have more of a brain fog, problems with memory and thinking, some have more of a heart, lung, breathless, chest pain type of presentation. So I think a lot more work needs to be done to work out, what are the differences or commonalities between these different clusters? Why would one patient get a particular symptom as opposed to another. I don't think we're really there yet.
And you've got a question?
Hey, thanks for, outlining the treatment plans for people with fatigue. Are there similar protocols for people with things like brain fog or like loss of smell or, vertigo? Could you outline what those are?
Loss of smell is a great one because there's a system that can be we train people to identify smells, and it's been developed in the United States, and we've been using it in a number of our clinics. So that's a good question. The other part about brain fog, essentially what we do is the treatment is to characterise it by doing the tests. We often pull in a neurologist. We contact Bruce if we notice that there might be other symptomatology for him to review. Then we look at what function they can't do. So mostly it's work. I mean, the loss of productivity in an environment of low unemployment and high workforce needs is huge. So we look mostly at their work, and we then analyse their work. We get an occupational therapist to do that, and we try and then fashion a return to work based on what cognitive power they have as opposed to the weakness. And then we also give them some exercise because this certainly in other neurological conditions, exercise can often improve the vascular supply to the brain. So we do some of that, and we'll also, if there's psychological phenomena, particularly if people get depressed, which often happens because they get insight into the fact they're not functioning well, we'll treat that with psychological techniques or even medications. So it's a multidisciplinary approach, and we tell the people not to expect too much and slowly pace their return to work. And recently we discharged a lawyer back to full-time work after about 6 months in the program with cognitive impairment initially, doing a very slow return to work and working with his employer. And there's only been 2 or 3 in that category because we've not been running for very long.
Look, we've pretty much run out of time, but I want to thank you for those really interesting questions. It's certainly been a very interesting discussion today. We've heard about some of the extraordinary work taking place throughout the pandemic and the efforts that remain underway, particularly for those facing long COVID. Consistent with its mission of providing excellence in healthcare, particularly to the most vulnerable in the community, St Vincent's will continue to strive for better treatments for acute COVID illness and for long COVID through research. Thank you to the wonderful St Vincent's Curran Foundation team for organising tonight. Our enduring gratitude is reserved for our St Vincent's family of donors and supporters. Your support for St Vincent's hospitals ensures their strength and capacity to care for our patients and protect the health of our community when it is needed the most. And the COVID pandemic is most certainly one of those times. I've got to say, and you heard Gail talk about it, how rapidly the ADAPT study was set up. And you know, a few friends of mine said to me, your researchers are very fortuitous that so quickly they established this ADAPT study. And not to detract from your fortuity, if there's such a word, and your vision, David and Gail and Stephen and Bruce, but I did actually touch on the fact that we are very fortunate at St Vincent's. It's one of the great differentiators that we have this extraordinary and very sensitive and very well adjusted support base, and the St Vincent's Curran Foundation having that incredible sensitivity to share a vision, see our need and work hand in glove with us is like no other hospital gets to experience. And it is really one of the great differentiators on this campus, in addition to this wonderful group of panellists next to me. So I hope you can all leave here feeling very well informed, as I do, about our collective future of living with COVID. Thank you again to our wonderful panellists. If you would like to find out more about how you can support the St Vincent's COVID response, please get in touch with one of our foundation team or visit the foundation website at supportstvincents.com.au. Good evening and thank you so much.